Innovation, imagination, wonder. These are just some of the words used to describe Dr. Harvey Passes. Dr. Passes explores interesting people and ideas that will stimulate you. He questions the people who develop, create, and employ novel concepts in business and everyday lives. He especially loves to speak with successful people. How did they do it? How can you do it too? So let's join Dr. Harvey Passes in his quest of wonder and curiosity as we watch Dr. Harvey Passes Presents.
You know, I must tell you, there are times when you have things that happen to you that you just remember them and you still go on. You still go on and they affect you heavily. One of them would be if you're a male, and you and your wife, or if you're a female watching this, you experience a miscarriage. That is not a pleasant experience. That's something that stays with you, and you think, how did this happen? How could it have happened to me? Was it an omen? Was it this? And you start thinking some old wives' tales about it. I have a dear friend of mine who is one of the most prestigious, most knowledgeable people on this subject. And in fact, he has written a fabulous book explaining all of this to try to help you understand how this does not have to happen to you or any one of your loved ones. And first I'll show you the book, and then I'll have you meet Dr. Jonathan Scher, and you'll get a chance to learn a little bit about him, and then stay tuned for this most interesting show. First, here's the book, and it's called Preventing Miscarriage. And the bottom part of the book says, which I like, it says, the good news, preventing miscarriage and the good news. And it's a fabulous book. I enjoyed reading it, and it was, as I said before, it was a whodunit.
Right.
It was a very interesting, I know, it wasn't me. Anyway, it was very, very, very interesting book, terrific. And Jonathan, I want to thank you very much, Dr. Scher, for coming down.
Thanks for having me.
And taking your time from your extremely busy schedule. Let me tell you a little bit at home, a little bit about Dr. Scher and his background. He's a physician, and he's a fellow of both the Royal College of Obstetrics and Gynecology in England and the American College of Obstetrics and Gynecology here. Additionally, he received a doctorate for research on prostaglandins, which are hormones involved in pregnancy and labor and other things in dentistry, too.
Right,
But that's another
sure.
story. And he has numerous scientific publications in peer-reviewed journals and is the author of 3 books. And the most recent is the one that we just shoved in your face. He started the first pregnancy loss clinic in New York City. You know, I didn't realize that about you. And Dr. Scher is on the staff of Mount Sinai Medical School, which I know, in New York City, and you got a private practice, which I certainly know, in Park Avenue. Well, you're not my doctor, but anyway, where he specializes in the treatment of recurrent miscarriages or miscarriages. Either way, one's the person, the other is the act of, which would be unexplained infertility and patients who repeatedly fail IVF. What was IVF?
In vitro fertilization.
Okay,
Right.
just testing it.
Okay.
Okay, so let's get into it. This is a fascinating subject. I know people are really listening to this right now. First, explain some of the myths. What are some of the myths that people are living with every day?
Well, one of the things is something that you mentioned, and a very important myth to mention is that miscarriage is nature's way of getting rid of an abnormal baby or abnormal tissue.
Yeah, you hear this all the time.
Right, and there's nothing further from the truth.
Go ahead.
And we're talking about recurrent miscarriages, more than one back-to-back, and I think that's the most important thing. Some of the other miscarriage myths that are important are that there's nothing that you can do about it, that there are no tests available. And today there are many tests we can do, and there are things we can do when we find the cause to prevent the miscarriage recurring. We can't guarantee the results, but in a lot of cases we can stop it from recurring.
So it's not a matter of just saying, well,
No.
it happens
Right.
there,
Yeah.
and just try
Yeah.
again.
Yeah.
We have to find a reason.
Right. Sometimes it's treated like the weather. Don't worry, it'll get better. And people suffer through repeated miscarriages or repeated failed in vitro. And they just do the same thing over and over again. And that is something that should be corrected, and something can be done about it.
So the cause of recurrent miscarriage is truly not unknown. There is usually, if you dig deep enough and if you try hard enough,
Right.
you can find out.
There is a small core
That is
of unexplained or unknown, but fortunately that core is getting smaller and smaller and hopefully will disappear. We know that we can find the cause in many cases, and for these causes, treatments are available.
Okay, that was my next
Okay.
myth,
You're right.
and that is that someone says, well, it's really a shame. There isn't much that can be done. Not true.
Absolutely not true.
Absolutely not
Nothing
true.
is further from the truth. If the causes are looked for, and you know what should be done about them, a lot can be done.
Okay.
And that's the point.
Okay, how did you get interested in this?
Well, I've been doing this obstetrics and gynecology for a long time.
About 2 years, 3 years.
A couple of months.
Okay.
I don't tell you how long. Okay.
Not asking.
And I noticed years and years ago that the problem of miscarriage was a very difficult one. It's extremely frustrating, and there was so little notice taken of people who recurrently miscarried. And I think it wasn't until the early 1980s that psychological studies have showed just how devastating it was for a couple to recurrently miscarry. And that also happened at a time when more research and more modalities were becoming available to investigate early pregnancy. The advent of ultrasound was one thing. And that was a big boon, because at last you could look at the baby in the uterus from early on.
I'm amazed when I've seen those pictures.
Right. The second thing was the ability to measure hormones and do endocrine tests, because before the 80s, it was very difficult. Today, if you want to measure someone's hormones, your blood gets drawn, your doctor should call you the next day with the result.
Right.
But in the old days, I mean, it was like a joke. It took 6 weeks to get a pregnancy test back, by which time you obviously knew you were pregnant. So I think these things have helped tremendously. And at that time, I noticed the frustration. And we started treating the patients, giving them hotlines to contact us if they miscarried. And we had very few tests and treatments available, and now they've developed over the years, and there's a lot that can be done.
What's the difference between, or is there a difference between miscarriage and spontaneous abortion?
Okay, miscarriage and spontaneous abortion are synonymous.
Aha.
Synonymous. And the term spontaneous abortion is a very sad one, because it's very inappropriate, because the word abortion suggests that it's something induced, almost a criminal intent, and we should really drop that term, and we now talk about not a missed abortion or spontaneous abortion. We talk about a missed miscarriage or a spontaneous miscarriage. But you're correct. I mean, they mean exactly the same thing.
People should understand this.
Should understand
How
that it's
common is it? For a miscarriage?
Spontaneous miscarriage is extremely common. In fact, about 15 to 20% of clinically diagnosed pregnancies.
15
to 20%.
It's that high?
Very high. In other words, the woman has missed a period and has a positive test, miscarry.
Wow.
And almost an equal number miscarries between conception, around about day 14 of the menstrual cycle, and the first missed period. Those are called chemical pregnancies, which we can now diagnose because we have sophisticated hormone testing.
Now I'm going to ask you a question, and we can have a lot of fun with this question.
Right.
But I'll ask you, and I don't want your answer to be, well, you go to Victoria's Secret. How does pregnancy occur? First, you got to buy her a drink. No, okay.
Well, that's part, Harvey, that's part of it. You should know that, right?
Okay. Tell my wife.
Can I use a diagram now, may I?
Sure. Keep it clean. No, I'm only kidding.
All right. Okay.
Well, let me hold it up.
Okay,
use my pen.
Okay, if I might.
Sure. We're going to get a close up here. So tell me when we're on, and we can start pointing. We can discuss what goes on here, and you can begin right now. Go ahead.
This photograph, this cartoon shows the uterus and fallopian tube and ovary.
Right.
This under these projections is the top of the vagina.
Right.
This is the cervix, the entrance to the uterus, to the womb. This is the cavity of the uterus or womb.
Right.
And this is the fallopian tube, which runs all the way around on either side to the ovary.
Right.
And when a woman reaches puberty, a woman is born with all her eggs. One egg each month comes to the surface as it ripens.
Right.
And the tube, very much almost like a vacuum cleaner, covers the area where ovulation, where the egg's going to be expelled, and it gets wafted into the tube.
Right.
And this is usually about day 14 of the cycle, round about there. And when sperm are deposited during intercourse in the top of the vagina, they get trapped in the mucus in the cervix, and the sperm swim along the tube, and about day 14 and a half, these little tadpoles are the sperm, they fuse with the egg. And this now starts to divide the zygote, and it takes about a week, and it enters the uterine cavity. Now what this has to do is to implant in the uterine wall, because the blood supply comes in from outside.
It needs nourishment.
It needs nourishment, otherwise it cannot survive. Sometimes, of course, the egg sticks in the tube, and that's called the tubal ectopic pregnancy, but that usually doesn't happen.
That's not good.
Not bad news. Once it's in the uterine cavity, it grows in, and it starts to infiltrate or to grow into the uterine lining about day 21 of the cycle. That's when implantation occurs, between day 21 and 24. That's known as the window of implantation. And now the baby will grow, fill the cavity, it's got the blood supply. And I just want to say that some of the advances we talk about, the recent advances for early recurrent miscarriage and failed in vitro, is this area, the failure of implantation.
That's the biggest.
This is where a lot of the research is going on now, because what has been shown is that unless this embryo buries itself deep in the wall and gets a good blood supply,
it won't make it.
That's where the trouble, nearly all pregnancy problems arise there. Chemical pregnancy, didn't even know they were pregnant, they didn't miss their period, early miscarriage, late miscarriage, baby not growing well, preeclampsia, abruption where the afterbirth separates, all start at the time of implantation.
I see.
So that's how it occurs, beside the glass of wine. That's how it occurs.
I like the first part. So anyway, okay, so now we understand how that happens.
Yeah.
And the whole thing is truly amazing.
Amazing. Can I just tell you something very fascinating about pregnancy? And I mean, it's extremely interesting.
Go ahead.
Is that okay?
Sure.
Pregnancy is the only example in mammals where something foreign survives in the body. Because if you think about it, half of that embryo, that fertilized egg, comes from the partner, from the male.
It's an antigen.
And that's foreign. And if, for example, you had 30 men, and a woman needed a kidney transplant or a corneal transplant, and they thought, well, she's a nice lady, I'll give her a kidney. You can bet your bottom dollar that none of them will be accepted. They'll be rejected by our body. And yet pregnancy survives.
Why?
And for 40 weeks.
Why?
Well, we don't know exactly why, but you have to believe in God. It's such a wonderful mechanism. But essentially what we think is happening is that there's some immune signaling, some communication between a protein that's only in the father's half or the paternal half of that fertilized egg. And if the mother's immune cells in the lining of the uterus, because every surface has immune cells, pick it up correctly, they still produce antibodies,
to fight it,
which I can explain further, to fight it, but they are the balance shifts, there are different types of antibodies. And it shifts towards the less toxic type. I can explain that further if you wish.
You can, certainly, because then I'm going to lead to the next comment that I have on that.
Okay. Well, every body surface, whether it's the surface of your eye, when someone coughs in your eye, or your gastrointestinal tract, if you eat a salad that someone hasn't washed their hands when they made it,
in your nose,
the immune cells in the lining of our body surfaces in men and women have immune protective cells. They call them T cells. Imagine a T cell is a little fire extinguisher that you see in the theater or at a service station.
So
yes. We just happen to have.
Let's get a shot here. Let's get a picture of this. Okay. So keep talking. So now you've got your T cells.
May I borrow your pen?
Sure.
Thanks, Harvey. And imagine the T cell is this man or the little fire extinguisher. and the flame is the foreign germ. Now that is in the lining of the uterus. The germ is the germ in the salad or anywhere else, or someone's coughed on you, and the foam coming out to destroy it is the antibody. That's immunology in a nutshell. But
in a nutshell,
the rest is complicated technical detail.
But this is immunology 101.
And just as if you know any firemen, they will tell you that these fire cylinders do not all have the same foam.
Right.
Some of the foams are for electrical fires, some for wood fires, some for chemical fires.
Right.
Yeah, and by the same token, the body has different foams. And when pregnancy comes along, we think that the foreign part in the husband's half of the embryo signals the mother, and the mother receives a signal. It's backwards and forwards between the two bodies, and the foam that comes out is a slightly less toxic one. The body has different foams or antibodies, and it gives it a privileged position and allows the pregnancy to grow. That's one of the current theories. That's not accepted by everybody, but it's a working theory.
That's very interesting. What about an individual who has recurrent, recurrent cough? No, an individual with recurrent miscarriage.
Yes.
And then eventually, would she not possibly get a blood transfusion? Was there any value in that, in trying to gain acceptance?
Well, you're actually right. You know that if you want to stop rejection in medicine, they noticed that when someone had a blood transfusion, it stopped rejection. But of course, we don't do that. There are other ways to treat immunologically now. But you're right. A blood transfusion will prolong survival of a donated organ.
Well, absolutely. That's why I was asking you about that.
Interesting. There's a lot that's not understood, but there's a lot that is understood.
What kind of conditions that could be handed down might get in the way?
Okay. When we investigate someone who's had recurrent miscarriage, we first make sure we've done all the basic tests. All the basic tests that we do on everybody who recurrently fails IVF or recurrently miscarries. And we can go into these. But there are hereditary conditions, and in medicine and in recurrent miscarriage and in gynecology, whatever specialty you're in, the patient's history, the story is still critical. To take a careful history of when the miscarriage occurred, how many they've had, what stage did they get to, and it gives you an idea of what the cause might be, and we then direct our investigations. And there are hereditary factors, particularly factors that interfere with the blood flow to the early embryo as it's implanting.
So that comes back to what you said earlier. Right. Because now the embryo doesn't get nutrition.
Absolutely, that's where it starts. Yeah, so there are conditions that are hereditary, and there are many others that are acquired, either as the patient ages or from exposure to various toxins or whatever you like.
So an individual unfortunately miscarries.
Right.
What do you tell them? What should they do immediately?
That's a very good question, and I think that's something that needs to be emphasized. If a woman has had, certainly if she's had more than one miscarriage back to back, or that miscarriage is advanced, beyond the first trimester certainly, and she miscarries at home, then what she should do is collect the miscarriage tissue.
Tough to do.
It's very tough to do, and she might not be certain what it is, but the actual pregnancy sac looks greyish, looks different from the deep purple or red blood clot around it.
What does it look necrotic? When you say greyish?
It's grey and spongy.
Okay.
And then what she should do is collect whatever she thinks is embryonic tissue, and keep it in a clean container and put it in the refrigerator, not in the freezer. And, just leave it like that. Or if she has some contact lens solution, which is sterile saline, add it. And then as soon as she can the next day, take it to a doctor's office or to the hospital and request that the tissue be sent for chromosome, i.e. genetic analysis. That is so important, because it's always been touted that every miscarriage is chromosomally or genetically abnormal, which is absolutely untrue. But it's important, because if it is chromosomally abnormal, then you have the cause. And patients want to know why they miscarried. People want to be tested. They don't want to be left hanging, so that
that's correct.
They can accept the reality if they test it.
Absolutely. If you know, is there something in particular that the lady should say to the doctor if she miscarries?
Yes, I think that I want to be tested. Don't take no for an answer, because now, especially today, there's so many causes we can find and treatments that are available.
So don't accept it.
No, and don't accept it.
Because I must tell you something. I know a number of your colleagues, and certainly I know you, and your attitude is so magnificent. I mean, you are a very warm, generous, gracious individual. Your patients just love you because you're very caring, you're compassionate, you're considerate, and you also combine that with brilliance and not letting any stone be unturned. Now, why am I saying this? Because you paid. No, I'm kidding. I'm saying this. No, I'm saying this because
of the retainer. No?
Of the retainer. Okay. I'm saying this because there are so many doctors, OBGYNs, who won't go the extra way. They'll say, well, you'll just start again. Clean up the whole whatever it is, and let's just start again, without saying, let's deep. Yes. Let's go deep. Let's dig deep. Let's test. Let's find out. Don't just say, well, I'm very sorry.
Right. All the major studies, psychological studies, have shown that people want to be investigated even if the cause is not found. That's very important. The other thing is, a lot of these tests, I mean, they do require some effort on the caregiver or the doctor's part, and some compassion is required. And, even though I'm mentioning all these can I just elaborate a little bit
Sure,
what I mean? But
of course.
Even though I'm mentioning all these Western harsh medical tests.
But I know where you're going.
Yeah, I do believe in mind-body medicine.
I agree.
And if you do this, reassurance is very important. And I think if you do care for people, then you need to give them some TLC. In fact, I think TLC is so important in medicine in general, and in dentistry too. I'm sure that to withhold it, I think, is almost unethical. And you have to be compassionate when you do medicine,
especially in your field.
Yeah, it's a
my field too.
Your field too, and any test, the result of which depends on whether someone may or may not have a baby, is fraught with emotional overtones. And you have to understand that people get very tense about it. You have to give them the time, and I think that's very important. You have to run late.
Right, you have to run late. That was my comment I wanted to
Guilty.
make about you. You're very good at that. You're very good at that. You're guilty for good reasons. What is the commonest hormonal disorder in women of reproductive age?
Yes, I think there's a condition called PCOS, which translates into polycystic ovary syndrome.
Which means
it's the commonest hormonal disorder in the USA in women of reproductive age. It means their hormones are not in sync. The gears are out of mesh. And this condition's been known for at least 50 plus years, but it's only in the past few years that its importance has been appreciated. And its associations, metabolic and other medical associations. And it's now shown to interfere with good implantation. And, this is just an example of another test that should be done, a basic test.
It seems to me that if a OBGYN gets his training and takes some courses afterwards, and there are some people who just don't really pursue a lot of continuing education programs, and they're stuck within a certain time zone of treatment. Yes. And you go and you don't know. You go to your doctor, you don't know. But you have to be aware of the new things. You have to be aware of the new thinking.
You have to be aware of the new thinking. And there are some of the standard tests that we do are actually new, like looking for the polycystic ovary syndrome, like looking for insulin resistance, where people are not diabetic.
Insulin resistance, that's very important.
It's very important.
It's being implicated in so many conditions.
Very important.
From cardiovascular disease, and now we're talking about that.
Right.
Okay, listen, I got a bone to pick with you.
What's that?
I like doing this. On page 119, because I read your book, on 119 it says here now, we're discussing about other hormonal causes of miscarriage, and it says here now you're describing the cervix. The cervix is soft And in itself, this is not a painful injection. You're about to give an injection for either maybe doing a biopsy or you're doing some other treatments there. And you're letting the patient know that the cervix is soft, and in itself, this is not a painful injection when you give them a little Novocaine injection, much less so, even much less than when you get an injection from the dentist. when the dentist makes an injection into your firm gums before filling a cavity. Now, hold on a minute. Dental injections don't hurt.
I actually asked the publisher to delete that because it wasn't accurate. Obviously, I'm sorry, Harvey. You have the old edition of the new book.
It's very funny.
That was nothing personal.
No, well, listen.
Nothing personal.
It's okay. Listen, as dentists, we always get it.
No.
We always get it. Okay, now let's talk about smoking, drinking, coffee, and all those other things. Are they good or bad for before pregnancy and during pregnancy?
Okay, there are certain lifestyle factors. You can't do anything in life about acid rain, but you certainly can about things like smoking. Smoking's a no-no. Couples, pregnant women, and certainly their husbands and people around should not smoke around pregnant women before, during, or after pregnancy. This is the one thing that's bad.
Bravo.
You see, people ask about smoking. That is a no-no. Alcohol, an occasional drink actually is not harmful. The problem is we don't know the safe limits, so drinking's discouraged. But certainly, occasionally you go to a wedding, have a special celebration.
Well, you're upset and you're nervous.
Upset and you're nervous. An occasional drink
of wine,
will not cause any harm.
Not a glass of scotch.
No, but an occasional glass of wine. I mean, we used to treat premature labor with intravenous alcohol.
So there you go.
But drinking is to be discouraged. Exercise in moderation. That's important. Caffeine is another subject that's often brought up. Can I drink coffee? Yes, you can. You can drink 2 fully brewed cups of coffee a day.
Caffeinated,
not
caffeine.
Caffeine. Up to 300 milligrams a day is safe.
Oh, does that cross over the placental barrier?
It crosses the placental barrier but does no harm.
Okay.
Decaffeinated coffee, of course, as much as you like. It has 0 to 3 milligrams of caffeine.
Right, so
and it's
you
safe.
need a lot to catch up to the number you're giving. We're almost going to be out of time. Here's the important question now. When does one give up? And one say, maybe we'll look for, adoption.
Okay. That's a good question, but it's a difficult one to answer.
You got about 30 seconds to answer it.
Let me tell you what it is. Providing all the tests have been done, and it hasn't helped, and there's this hardcore, then it's a time to go for ovum donation, sperm donation, adoption, surrogacy. But please, this idea of unexplained is often used as a cop-out. It's not unexplained when you look for endometriosis, you look for immune factors, the newer ones, some of which are standard now. Only then can you call it unexplained, and hopefully this unexplained area will shrink further and further. But there is that small core, providing everything's been looked for, where you're not successful.
We're out of time. I love talking to you.
Thanks, Harvey.
You're a
Thanks
gentleman.
for having me.
You're wonderful. You make people feel good, which is very important in being a human being, let alone being a physician.
Okay.
So thank you very much for coming down and explaining all of this. This was great. And if anything new comes up, give me a call. We can do a show on it to explain, because this is one great way of letting people know about all the new things that go on out there, and that they don't have to say, oh, it's a shame we just can't have any children. And, and this book is great. This book is excellent. If you're in a circumstance, Preventing Miscarriage by Dr. Jonathan Scher, fabulous book. It'll help you out a lot. Great book. Thanks so much for coming down.
Thank you very much.
You're a joy.
Enjoyed it. Thanks.
And I hope you enjoyed it and got a lot out of it. And until I see you again next time, whatever you do it with passion, and don't give up. Don't give up. Dr. Pass is saying, until then, so long.
Thanks again, Harvey.
It was great.
Thank you. You know what's important, actually, it reminds me.